I'm Helen Zorbas. It's my pleasure to welcome you to the second program on gynaecological cancer, produced by Cancer Australia and the Rural Health Education Foundation. We're delighted to have health professionals from rural and remote areas of Australia joining us for this program on endometrial cancer. Endometrial cancer is the most common invasive gynaecological cancer in Australia, and its incidence is increasing. Each year, about 1,700 women are diagnosed, about a third of whom live outside a metropolitan area. As rural health professionals, you have a vital role to play in the early detection of endometrial cancer and the investigations that can lead to timely referral and diagnosis. We hope that through this broadcast you gain a better understanding of those women who are at greater risk of developing endometrial cancer, as well as the importance of appropriate investigation of symptoms and referral for treatment.
Thanks to Helen Zorbas. Hello, I'm Norman Swan. Welcome to this programme on endometrial cancer. It's a programme which is a joint initiative of the Rural Health Education Foundation and the National Centre for Gynaecological Cancers, which is part of Cancer Australia. And this is the second programme in our series on gynaecological cancer. Endometrial cancer is the most common gynaecological cancer. It's on the rise in Australia due to an ageing population, an increasing prevalence of obesity and diabetes in women. Tonight we're going to discuss risk factors, signs and symptoms, appropriate investigations, who should you refer to, all of which influence whether or not you make a timely diagnosis and get your patient into treatment. You'll find a number of useful resources available for you on the Rural Health Education Foundation's website, rhef.com.au, and also on Cancer Australia's website, canceraustralia.gov.au. So let's meet our panel. Jenny May is a rural general practitioner working in Tamworth. Welcome, Jenny.
Thanks, Norman.
Jenny is employed by the University Department of Rural Health in Tamworth and is a rural GP academic. Jenny has a strong interest in making sure rural people get the same standard of healthcare as those living in the cities. Peter Murick is an obstetrician and gynaecologist working in Albury-Wodonga. Welcome, Peter.
Thanks, Norman. Good evening.
Peter's been working in that area since 1979. He also travels widely working as a gynaecologist throughout Australia and teaches women's health to medical students at the Rural Clinical School of the University of New South Wales. Kath Natras is a cancer nurse coordinator for the gynaecological cancer at the Sydney Cancer Centre. Welcome, Kath.
Thanks.
Kath is also a clinical senior lecturer at the University of Sydney, and her research interests focus on the impact of disease and treatment on women with gynaecological cancer. Michael Quinn is Professor in the Department of Obstetrics and Gynaecology at the University of Melbourne and is a consultant to the Oncology Dysplasia Unit at the Royal Women's Hospital in Melbourne. Welcome, Michael.
Good evening, Norman.
Michael is also a member of the advisory group of the National Centre for Gynaecological Cancer. I will do simultaneous translation for Kath and Michael, who both speak the same language as I do, but not necessarily where you do. And Jenny May is actually the only Australian-born Australian on the team, so have pity on her. But welcome to you all. What I thought we'd do tonight is actually show you a video we've made, actually in Peter Murick's hometown of Wodonga, about Marjorie, who developed endometrial cancer, and I think it creates a focus on the woman who experiences endometrial cancer.
I went to my GP for a routine pap smear, and I'd had no signs or symptoms or any worries at all. And on the pathology report of the pap smear came back that there were some endometrial changes, probably benign. And I can remember very clearly my GP saying that he was not happy with the probably benign. He didn't want to put it off for 6 months or 12 months. And he referred me to a gynaecologist in Wodonga, where I had an ultrasound which showed some thickening of the lining of the uterus. He recommended to have a curette, and the pathology report from the curette was that there was endometrial cancer. Living in Albury-Wodonga, I had to go to a cancer specialist in Melbourne for treatment. That is quite overwhelming when you leave the security of your home and your family and friends to go to an unknown place. You have to organise your home base so that it will work whilst you're not there. Because of some complications with surgery, I was down in Melbourne for about 6-7 weeks, and that caused another huge considerable stress for my partner. Even though I am well past having babies, the fact that I had a hysterectomy and all of those parts that make me a woman have been removed, there is a sense of loss, same as a woman who has her breasts removed. There's an enormous sense of loss because it's part of your femininity and part of your womanhood, and I think that that's something that you have to think about and come to terms with. I think having had the experience of cancer, I think it has made me very much more aware of my body and my health. I make sure that I keep up my regular appointments with my specialist and general practitioner. Hi, I'm here to see Dr. Marek, please. If I find that there is something worrying me about the endometrial cancer, being able to go to my specialist and discuss a concern with him, I find that that's very reassuring for me. Oh, it's good to see you again, Peter.
And how have you been since the last 6 months that I saw you?
I have been very, very well indeed. Very well.
Wonderful. It's 2.5 years now since you went to Melbourne for the big operation for the endometrial cancer, that's correct?
Yes, my trip to Melbourne was a very, very big event in my life, a very dislocating one, and a very, very scary time for me and my family.
You're very fortunate compared to a lot of country women in that we are able to do your follow-ups, because that can be quite an arduous round trip of 600 kilometres.
To leave your home to go to the city for treatment, I think that you have to ask for help, either from your family or friends, perhaps at your GP's rooms or your specialist rooms or your counsel. Go to those places and ask for help.
You've had a wonderful result from the histology. The tumour was very early, and that's because you presented before you had any symptoms. And that means that the prognosis and chance of having any tumour come back is exceptionally small, probably 1 or 2% in your case. But we still have to do the follow-ups like you're doing today, and it's important to keep an eye on you. And at the end of our interview today, I'll do a letter and I'll send a copy to the Melbourne oncologist so that he can keep tabs on you as well.
I've often wondered whether a specialist or a GP would benefit from a patient's personal experience, and I've often thought, could I ask that practitioner to put themselves in my shoes just for a moment, to understand that that patient really needs a lot of reassurance after your treatment. You can be very anxious. Every pain and ache can be the worst possible diagnosis.
Well, Marjorie, I've got really good news for you. The examination was perfectly clear. I will have a result of the pap smear in a week's time, and I'll get you...
With the encouragement of my gynaecologist here and the general practitioner, they reassured me and gave me as much information as I wanted to know. That was very helpful to me and helped me to sort of get the diagnosis of cancer into perspective. And so I was very happy about that communication that I was able to have with both of those doctors.
Lovely to see you again. It's been a pleasure, and I'll see you in 6 months' time.
Marjorie's story from Wodonga. So she's a lucky woman that she had a good GP there who picked her up on the pap smear.
Had a very good GP. And she just had a routine pap smear, and the abnormalities were picked up, and they were equivocal. And he wasn't too sure, and he said to her, Marjorie, I'm not sure, I'll send you to the local specialist.
Typical story for women in that ambivalent situation of stay at home, get referred to the major centre, Jenny?
Often the story. People often like to stay local or like to know a lot about where they're going.
And Kath, that sort of the typical story of people not expecting her still to be a sexual person.
Definitely.
Even at 72.
And she comments on that, and that even having a hysterectomy at that age still has associations for many women of femininity and sexuality. And how often do we address it as we should?
And did she talk to you about that, Peter?
She has talked to me about that. I've known Marjorie for 30 years, which is a lifetime really, and we have discussed that.
And of course, sometimes those boundary issues, when you've known somebody that long, become a bit hard.
Yes, I was just reflecting on that as Peter said it. Sometimes it's easier to talk to someone who's actually a little bit more anonymous about some of those things as well.
To what extent, Kath, I mean, your experiences in New South Wales, does the multidisciplinary team care that you get in the major centre translate back to the country town? Because obviously somebody like Marjorie continues to need it in some shape or form.
There are generally very good links that we should be making with particularly the GP when that woman goes back to a country town, but things like within New South Wales we have the regional cancer nurse coordinators who are cancer generic, not cancer specific. But so if a woman is, say, going back to Dubbo, I would speak to the cancer nurse coordinator there, and we will liaise between us, so she may well call me on more specific gynaecological cancer related things. And actually, when that woman's at home, you're still only on the end of a telephone, and a great deal of things can be done over the phone. It doesn't actually need to be face to face, so just because she's however many miles away doesn't mean she's not still getting that support.
So Michael, the commonest gynaecological cancer, that surprised me.
Oh, by far. I mean, much more than any other cancers. We've got almost 2,000 now coming up in Australia annually. When you look at ovary cancer, it's about 1,400, and cervix cancer, we're now less than 700. So, you know, this is 3 times as common as cervix cancer, but most women are much more preoccupied with having their pap smears than actually worrying about the risk factors for endometrial cancer.
What are the risk factors?
Well, over and above everything else, it's estrogen related. So obesity is the #1 factor, and that's why we have a worldwide epidemic of this disease. We've got about 30,000 American women every year get cancer of the endometrium, and about 6,500 of those women are going to die. So it's a very common cancer. It's a cancer that will unfortunately kill about 25 to 30% of those women. So it's a real issue in Australia as our population is getting more obese, as diabetes is getting more prevalent, and as our population is aging.
So it's a pretty big relative risk for obesity.
It's enormous, and it's the single most important thing that contributes to this.
And that's
disease.
estrogen.
That's estrogen. It's the same as being on unopposed estrogen. Of course, thankfully, we don't give unopposed estrogen anymore. Yep.
And diabetes, is that insulin growth factor? What's the story there?
Well, you're absolutely right. It's an insulin-related phenomenon due to aberrant growth factors within probably the ovary, causing stromal hyperplasia and estrogen production even in the postmenopausal ovary.
We've actually got a web question from Marissa Pillar, who's from North Queensland, acknowledging that this type of cancer is on the increase due to us getting fatter and more diabetes. And the question is, should we be routinely screening in some sense for endometrial cancer, particularly amongst Indigenous women?
It's a terrific question. The answer is no, we don't have a screening test available for endometrial cancer. Ultrasounds has been shown not to be cost effective in reducing the death rate from this cancer. There's no blood test available. So currently we have nothing that we can recommend for screening, and the only situation where it might be of value would be in a very high risk patient, and that would be a woman who carries a genetic mutation for what's called a mismatch repair gene, and these are women who've got hereditary bowel cancer. And
so this is Lynch families.
This is Lynch families. They've got 50% chance of bowel cancer, 50% chance of endometrial cancer. So we currently recommend that those women should maybe have at least an ultrasound, perhaps an endometrial sample done every year to see what's going on at uterine level, but no evidence to show that that reduces a woman's risk of dying.
And when you say ultrasound, you're talking about
transvaginal ultrasound.
Yeah. And there are different types. There's type 1 and type 2, and they've got different prognoses.
Yeah, we now know that the estrogen-driven cancers are, if you like, the good cancers. About 80% of all endometrial cancers fall into this group. And if a woman has this estrogen-driven cancer, she's got about a 90% chance she's going to be cured of her cancer. But in comparison is the type 2 cancer. It's much more aggressive. It's usually a grade 3 or a serous tumour. They're not estrogen driven. The woman doesn't have those risk factors that she would have for the type 1 cancer. And these women unfortunately have got about a 50 to 60% risk of dying from the disease. So it's a very bad cancer to get.
And the risk factors for the type 2?
None that we know of. So we can't target a high risk population, unfortunately, to try and reduce the death rate from
How similar is it to breast cancer? A lot of the risk factors are the same.
Well, I think certainly for type 1 cancer, we know obesity is one of the risk factors for breast cancer, as it is for endometrial cancer. And interestingly, obesity has been shown in a very big Australian study to be a risk factor for mucinous cancer of the ovary. So obesity, no matter which way you look at it in general practice, it's the #1 disease of our time.
And does treatment change according to type? So if you pick up the histology that it's type 2, do you go for things more aggressively?
Well, the type 1 cancers tend to be the well-differentiated cancers, and they're the type that are less likely to spread in comparison to the type 2s, and they're more likely to go to the cervix, go to the tubes and ovaries, go to the lymph nodes, or go to the omentum. So those are the ones we definitely concentrate on, and we spend more time staging the cancer, if you like, as opposed to the type 1.
How much of a risk is tamoxifen? There's a lot of women on tamoxifen.
Yeah, I think a lot of family doctors ask me this question: should we be screening women on tamoxifen? And the answer is no. The recommendation is that the risk would be about twice that of the general population risk. And when you look at obesity as a risk factor, it's up to 9 or 10 times. So obesity really is the #1 thing, and the way I explain it to women is your risk of getting endometrial cancer on tamoxifen is the same as getting an increase in risk of breast cancer having 1 alcoholic or 2 alcoholic drinks a day, because that's what it amounts to. Yeah.
And protective factors? The pill's a protective factor.
Pill's terrific. Pill's a great drug for stopping cancer, and lots of other things too. So pill does reduce the risk of endometrial cancer, anything up to 50% for 10 continuous years of use, and of course it reduces the risk of ovarian cancer as well. So the pill's very good for the female genital tract cancers.
Presenting features, I mean, Jenny, what do you know as a GP about the presenting features? What raises the alarm bells for you?
Well, the most common presenting feature from my point of view is bleeding. And a bloody vaginal discharge is the normal, I guess, way that we think about it presenting, certainly in postmenopausal women, and an abnormal bleeding pattern, if you like, in our perimenopausal woman. So a bleeding pattern that doesn't fit, for instance, with their HRT usage if they're using it perimenopausally, or prolonged or persistent bleeding that doesn't follow a pattern that you could identify.
We'll come back to the presenting features in a moment, because we've got a question from Alan from Finlay Medical Practice. Asks, why does Marjorie go to Melbourne for an oncologist? Was there a special reason? Were the Albury-Wodonga oncologist not appropriate? I'm 150 kilometres away from Albury, and my endometrial cancer patients are followed up at Wodonga. Peter?
Well, she wasn't my patient. It was my colleague that referred her to Melbourne for his own reason, but he suspected that it might be technically quite difficult because she was plump, if that's a polite word, and it can be a challenging operation when you have limited resources. But in fact, in retrospect, with the aid of the retrospectoscope, she may have been better to have been managed locally, because she had a very superficial lesion, no penetration at all, and she had a horrendous post-op complication. And of course, in the country, we wouldn't expect to see that.
Absolutely. No complications ever from surgeons in the country. But you might not know that before you go in, do you? That it's a nice superficial lesion?
No, that is the most difficult part, is to know what you're dealing with, except if you've got a well-differentiated type 1 tumour. In someone who is asymptomatic, you can suspect that they're not going to be grossly invaded.
And from your point of view, what's the most difficult thing that GPs often talk to you about, Peter, in terms of wondering whether or not this is a woman with endometrial cancer?
Probably the most difficult thing, as everyone knows, is the shortage of gynaecologists in rural areas, and they're fully booked, and they can be booked for 3 or 4 months for routine appointments. And I would like the GPs to be aware that this is a problem that needs a phone call and a personal communication with the specialist, not just to say to the lady, you need to see a specialist, because when she rings up, she might be told by the lady on the desk, who has no idea what postmenopausal bleeding and the significance, and gives her a 6-month appointment. And I think that's unacceptable.
But what about the symptoms? What gives you the most heartburn?
Well, as I said, vaginal bleeding is the symptom par excellence that got my sonar
But it's relatively easy if it's postmenopausal woman,
yes.
But if she's not quite through the menopause and you're not quite sure, that can be difficult.
It can be very difficult. And as I said, I mean, if you've got, as many women are, if she's on HRT, then it often makes the decision even more difficult, because you're looking to try and work out, is this actually a progesterone withdrawal bleed, as you would expect, or is it something else?
Michael Quinn, what about other things? I mean, bleeding is the hallmark. Do you often find endometrial cancer with no symptoms at all?
Very, very rarely, and this woman's been extraordinarily lucky. Getting an endometrial cancer picked up in a smear test is most unusual, and accounts for less than 1% of the total patient load that we carry. And as Peter says, that's obviously going to be a very, very early cancer under those circumstances before it's even caused any bleeding. So she's been very, very fortunate. Unusual.
Now, in ovarian cancer, we're still not sure that early detection would make a difference to the outcome. Do we know that with endometrial cancer?
We don't have that information either.
So it's an act of faith, the early.
It is, but the thing about it is, I think, as Jenny says, it's the bleeding. So bleeding is that trigger. It's a lovely symptom, if you like, to follow. And as soon as a woman who's postmenopausal gets bleeding, she usually goes to her family doctor. She plucks up courage and recognises that this is abnormal. Yeah.
What about overlap with symptoms of ovarian cancer, with abdominal symptoms?
Yeah,
pain,
very few. Certainly in my experience, most women with endometrial cancer just present with either irregular bleeding if they're premenopausal, and remember 25% of these patients are going to be premenopausal, or postmenopausal bleeding, or as you say, Jenny, a watery vaginal discharge that's blood-stained. That's not uncommon. Yep.
So premenopausal, just talk to me about how, I mean, that would be inspiring fear in the hearts of GPs watching.
Absolutely, and it's a tough one, because when we actually looked at the data, a third of those women with premenopausal endometrial cancer presented with heavy periods, and it's such a common symptom in general practice. And most general practitioners often examine a woman and they'll say, well, I'll put you on the pill and that'll sort it, or I'll put a Mirena and that'll sort it out for you. Yeah. So it raises that spectre of, am I under treating this patient? But probably not. And I think the premenopausal women, more often than not, will have the irregular bleeding, as you say quite rightly. And it's not the infrequent bleeding, it's the more frequent bleeding, and that raises the alarm bells.
In other words, there's a pattern of increasing intensity.
I think you do the same investigations. You know, if she's got irregular bleeding, it's exactly the same as if she had postmenopausal bleeding.
Yeah. Question from Dina Case from Queensland asks, is there an association between endometrial polyps and endometrial cancer? If an asymptomatic postmenopausal woman has a visible polyp at the cervix, should she have a vaginal ultrasound to measure endometrial thickness?
No. There's no link between
so this is a
cervical polyps and endometrial polyps.
But there is between endometrial polyps
and cancer, yes.
Right.
So if you have an endometrial polyp and this is picked up as an incidental and you're being screened for some other situation, the risk of that being malignant is only 1%. It's very, very low, but it's there.
We're jumping ahead of ourselves a little bit, but I might just ask the question. Albert Vermeulen from Northwest Health asks, premenopausal women with symptoms and endometrial hyperplasia, would you prescribe HRT if she insists, and how would you follow up? One of your hobby horses, Professor Quinn.
It is one of my hobby horses, because the management of hyperplasia in Australia, I think, is not handled well. And it's because we've changed the terminology, and our brothers and sister pathologists have introduced the term complex hyperplasia. And as soon as complex has come onto the scene, people have panicked. But they don't need to panic, because the most important thing in hyperplasia is whether there are atypical cells there or not. And if you have just complex hyperplasia, the chances of you subsequently in the next 10 years getting a malignancy is 1%. Whereas if you've got atypical hyperplasia, you've got a 20 to 40% of already having an underlying cancer. So that's the most important thing. So if it's simple hyperplasia, another great indication for a Mirena. Jenny?
For an IUD.
Yeah.
Absolutely.
Well, a progesterone-lined IUD. Yeah.
Let's go to our next case study, who's Mary, postmenopausal woman of 54. She comes to see you, Jenny, complaining of blood-stained vaginal discharge. She's got a BMI of 33. She's got a sedentary job. She's got type 2 diabetes and is on metformin, and she's married with no children. You're a patient.
Well, thanks, Norman. I think the first thing in general practice is a good history, and that's the way I would start. So I'd want to know particularly about that bleeding. When did it occur? Was it related to intercourse? Was it something she'd noticed regularly? Was there any pattern to it? I guess also what we were mentioning, other symptoms. As I said, did she have any pain on intercourse, or is there any abdominal pain? And when was she menopausal? So is this bleeding that could be related to her perimenopause, or is this bleeding that has come subsequently or a significant time after menopause?
So she tells you she's been spotting a bit right through, so it's never really been free of bleeding, through the menopause, but not had a regular period for quite some time.
Right. Well, that doesn't help as much. One of the other things that I guess we need to inquire into is medications at this point. So has she been started on any HRT, either cyclical or continuous? And also, has she been availing herself of any other estrogens? And I'm thinking here natural estrogens, because certainly it's my experience that a number of my patients have actually sourced natural estrogens thinking that they had no impact on estrogenisation at all in the way I think about it. And in fact, that has been a problem. And I think, Michael, that's something you're seeing also, that the bioidentical estrogens are not considered by the patient as estrogen or medication, but obviously from the point of view of predisposing them to or being unopposed estrogen, there's a big issue.
So they're just as potent.
And not only that, it's not just the patient, but it's also the complementary health practitioner who's prescribing actually believes that they don't have the same potency. And part of the problem, Norman, is we don't actually know what the potency is, because these are unregulated, so we don't know what the real concentration and what the real content of these particular medications are. But they certainly can cause an increased risk of endometrial cancer, and we've seen many cases, unfortunately.
So you're taking the history? What
yes,
else?
So I need to know about her family history. We've heard already that Lynch families are at high risk, so I need to know about that. I also need to know a little bit about her menopause and her menarche, and I guess did she have no children by choice, or was it that she couldn't have children, and in that case had she had PCOS or been anovulatory for a considerable period of time? So all those things are going to be important to try and paint a bit of a picture of whether this is significant.
And has she told you that she'd had endometriosis in the past? Or is there any relationship between endometriosis and endometrial cancer?
Not that I'm aware of.
No.
I wouldn't.
So what are you going to do next?
Well, I'm going to pop...
She had an uncle who died of bowel cancer at 45.
Okay, well that's
Maybe.
That might be helpful. I'm going to pop her up on the couch, because she's not going to leave the consult without being examined, presenting with this bloody vaginal discharge. So up on the couch, and I'm going to do a speculum examination and a pap smear, as we've already heard.
So you're looking for local causes of bleeding?
Yeah, I'm looking to identify where, if I can see an obvious bleeding source, is there pathology on the cervix, is there pathology in the vagina, and then I'll do a bimanual examination and have a good feel around and see if I can feel anything in her adnexia or try and feel her uterus. I have to admit that in a person more than 100 kilos, I have considerable difficulty in identifying anything, and if I can find anything or feel anything, I would suspect that that's abnormal.
I suspect experienced gynaecologists would find the same thing?
Very much so. It's a great problem. And especially if the woman's had no children, she's going to be more difficult to examine, and she'll have a cervix that's very difficult to expose, and it can be quite a challenge.
Okay, so you've taken your pap smear, there's nothing much to find, it was very hard to examine her.
So I'm going to talk to Mary, and certainly it sounds to me like this is a symptom that I'm going to investigate, immediately. I haven't seen anything grossly on her cervix that makes me think that it's cervical pathology. So I'm going to talk to her about organising probably a transvaginal ultrasound, and certainly that would be my next step.
Now that could be a bit of a surprise for her if you don't warn her about it.
Indeed, and I've certainly, it's my bitter experience that I've had patients come back and be cross that I didn't warn them, and that's because...
Because it's not a little probe.
It's not a little probe, it's quite a significant probe, and it is a vaginal probe, and unless they're warned about that, obviously that could feel quite invasive and quite disarming for them. So I talk to them about this probe that going to look a bit like a condom, and is going to be quite uncomfortable potentially to get a decent picture.
And in Tamworth, that's your local interventional radiologist who does that? Or?
That's indeed, or probably our local gynaecologist.
What are you looking for in TVUS and transvaginal ultrasound?
Purely the endometrium. That would be the number one thing in a woman with postmenopausal bleeding, and you're looking hopefully for a thin endometrium. Anything less than 5 millimetres, you're going to be pretty happy that the likelihood of malignancy is going to be low.
So this is generalised thickness?
Yep. It's
So you can have almost a
thickness.
carcinomatosis of the...
No, it's just a uniform thickening of the endometrial lining, and it's very difficult to see if there's an underlying cancer, if there is myometrial penetration on ultrasound. It's even quite difficult on MRI, and that's something we'll probably talk about later. Yep.
So there's a question here from Effie Parakilis. Sorry, can you comment on the diagnostic accuracy of a Papel endometrial sample under local compared to an endometrial sample collected via hysteroscopy? And when is it appropriate to do a Papel endometrial biopsy, and when is it appropriate to refer for a D&C? Varying in time, waiting times are long at public gynaecology outpatient clinics. I might ask you this first, Peter, and then I'll go to Michael on this.
Well, it's a procedure that most specialists do. I'm not sure whether many GPs would be able to do it unless they're quite comfortable doing Mirenas themselves and doing their own curettes, and they have the facilities. It is quite a simple technique. The correlation is quite good in that if you get tissue out, if it's an endometrial cancer, it usually fills up the whole cavity, and you get a sample which is very clearly malignant on histology.
This is simply a suction technique?
Yes, it's like a little suction catheter, 5 millimetres diameter, just slides into the uterus and aspirates the menstrual lining. And however, if it comes back negative, there are false negatives, and that would mean that they probably need referral for an anaesthetic and a hysteroscopy.
So coming back negative doesn't mean you can relax?
No, definitely not.
And what's the relationship between a transvaginal ultrasound and a Papel?
Well, there's a good relationship. If
you do both?
If you're doing both, then you can see where the Papel is actually going inside the uterus. But you don't need an ultrasound to do a Papel, and most gynecologists are very happy, particularly in the multiparous women, in doing a Papel. And the nulliparous women, and of course the nulliparous women is more likely to get an endometrial cancer anyway. It's a little more difficult. And then your transvaginal ultrasound says you've got 5 millimetres or more, then you have to do a hysteroscopy and curette under those circumstances. But the best thing is to do a Papel sample, if you can, in your office first up, and if there's tissue, you've got your diagnosis.
A question also from Effie is, I have a 75-year-old woman with postmenopausal bleed. Transvaginal ultrasound shows a normal 4 millimetre lining with a 2 millimetre cystic space at the fundus. Is it reasonable to do a Papel, or should she have a hysteroscopy?
That's a great question, and it's a common ultrasound finding. And the answer is do a Papel, and if you get tissue, fine, and if you don't get tissue, then you do your hysteroscopy.
Right.
Yeah.
Sounds as if you might...
Okay, Effie?
I'm not sure. Another question here from Albert Vermeulen, asking from Northwest Health, asking, is PCOS a risk factor for endometrial cancer, or is it just the fact that you're overweight with PCOS?
No, I think PCOS means you're not ovulating and you have unopposed estrogen production. And for some reason, I think that is, as we know, associated with obesity. So we're seeing younger women now in their late 20s, early 30s with obesity and PCOS together. And these women are developing endometrial cancers, and they want to have children. So that poses a therapeutic dilemma for us.
And in terms of any special, on the request form for a transvaginal ultrasound, is there anything that your radiologists ask for here?
Well, they need to know whether they're post-peri or premenopausal, I think that's, and whether they're symptomatic, I suspect.
Yeah, and I mean, I think most ultrasound people, when they get that form, will look at the ovaries as well, make sure there's not an estrogen-secreting tumour, or in the younger women, polycystic ovaries. And I mean, it's really quite sophisticated there. It really is fantastic, to be honest.
Peter?
I'd like to respond to that one, because one of our endometrial cancer patients, 120 kilograms, and when we told her the relationship, she said, oh, I must speak to my 2 daughters because they're large.
And we should just go back to that previous question on the waiting list at public gynaecology clinics. This is something that you as a GP, don't accept the waiting list. You've actually just got to get her seen straight away and no questions asked.
Well, this is about the patient advocacy, isn't it? I mean, this is about the fact that we know that, particularly in a postmenopausal woman, that a bloody discharge equals endometrial cancer until it's defined that it isn't. And certainly, as I said, access to ultrasound is either directly or through gynaecology services, and it's certainly important that you stay on that patient's case and actually get them seen if your clinical suspicion suggests that that's the most likely diagnosis.
Kath, at this stage, for this woman where she's not diagnosed, is there any role for someone like you in her, or this is just too early before she's got the diagnosis?
If there is access to someone like me, I think there really is a role for this. She is probably convinced she has cancer until proven otherwise as well. She's going to be in quite a state of limbo and probably has quite a lot of questions. What is this going to mean if this is cancer? And has a lot of unresolved fears while she waits for that diagnosis. So it's a really uncertain time, at which point there often isn't a great deal of support because she's not fallen into the cancer pathway at that time.
What happens, let's say she has a transvaginal ultrasound, Michael, and it's just on the margins in terms of thickness.
5 millimetres.
5 millimetres, and the bleeding stops.
And you've got no tissue on your Pipelle sample. Well, the answer is you don't go any further, but you say to the woman categorically, if you have another episode of bleeding, you need to contact me. And if you can get that message home, that's obviously very important. But having made the contact with the family doctor, she's plucked up enough courage, and I'm sure she would do that. Yep.
What's the process, Michael, for diagnosis then? So let's say the Pipelle comes back positive. That's it? You know, we just head for hysterectomy or what?
Okay, well,
or you do a DNC?
That's just, no, you don't have to do a DNC. Once you've got a histological sample confirming that there's an endometrial cancer, then you're hot to trot. And it's at that point you sit down with a woman and tell the woman what the likely implications of that diagnosis are, and what further investigations will be undertaken, and what's the likely surgical approach, because in the vast majority of cases women are treated surgically for this disease. Yeah.
How important is surgical staging?
Well, surgical staging is extremely important, particularly with high-risk tumours. And the problem is that even with the low-risk tumours, we don't know they're low risk until we properly surgically stage them. So it's a catch-22 position. So, and you'll see up on the screen there that even in women that we think have got early disease, up to a third of those women will actually have disease that we categorise as high risk. And by that we mean it's more likely to spread to pelvic and para-aortic lymph nodes. So we feel that surgical staging is important prognostically, so that the woman knows how advanced her cancer is. And secondly, it dictates her treatment. For instance, if we remove pelvic lymph nodes and they're not involved, we don't have to give that woman full pelvic irradiation, which takes 5 or 6 weeks. But if they're positive, then we know that she's going to benefit from pelvic irradiation. So the staging helps us in the management. It gives the patient information, and I think probably is the benchmark in 2011 in the management of women with endometrial malignancies.
Is there a value to the multidisciplinary team here, Kath, or not? Because it's sometimes hard to reconstruct in a country town.
There's a value in multidisciplinary team, but that doesn't actually have to be a sort of in real time sitting there at that one spot. A lot can be done by phone, as long as the liaison process is there and people know who to go to if they haven't got that level of information. You can have it doesn't need to be a physical team meeting there, it can be the virtual reality multidisciplinary team, and we often see that happening.
So Peter, this issue about where somebody goes, I mean, it's a bit clearer with a woman who's got ovarian cancer. But if surgical staging is so important, do you think general gynecologists in country towns can do that? Or?
It very much depends on the individual. There are some very talented gynecologists in the country, and I think the best person to assess that is the local GP, who may have had many, many years of working with that person. So he'll know whether he's had an interest in this work. He may have done extra training in oncology and is able to do the sort of node sampling that Michael's talking about. But Michael is talking about an ideal world where everybody's managed by in this level, but I don't believe there's any hard evidence to say that that improves the outcomes for the amazing cost of disrupting that woman and sending her a long way to people that they don't know. And occasionally they're managed in a city hospital by a trainee rather than someone who may have 30 years of operative experience.
No, I don't think that's ever happens. I don't think anyone is ever managed by a trainee. Peter, my view is that these cancers are life-threatening. I think they warrant, and when we ask patients, what's the number one thing you want when you're being treated for cancer? And the number one thing they want is to be sure that they are getting what they describe as cutting-edge care. They want to know they're getting the very best of modern care. And I think the occasional surgeon doing occasional lymph node sampling is not in that patient's best interest. So the surgery, I think, is important, but it's not just the surgery. Cancer care is multidisciplinary. It's the comprehensive care of the patient. And Marjorie spoke eloquently about the dislocation. But every patient who gets a cancer has a crisis. They get dislocated from their families, whether they're in the middle of Sydney or if they're in the middle of Tamworth. They have to go somewhere that they're uncomfortable with, they're threatened by. They meet people that they don't really know because not everyone knows the local gynaecologist that well. So I think it's very threatening no matter what. And the analogy is, if you've got coronary artery disease, your chances of living at 5 years are higher than if you get an endometrial cancer and treated even in a major centre. And you wouldn't go to your local gynaecologist to have your coronary arteries done, would you? Even although he was able to do them, or she.
Jenny?
Look, I feel very vexed about this. I hear both Michael and Peter, and I think, I guess my problem is a lot of these patients are elderly. A lot of these patients are, I'd like to say, not skilled at managing going to a city and some of the things that are involved, but that sounds patronising and I don't mean to be. But
with increasing prevalence of regional cancer centres which are based around bunkers, so you've got radiotherapy, then increasingly it's really only the surgery and the diagnosis they can have, and they can come home for their regional.
Indeed. My ideal world is something between the two of these extremes, if you like, because I would like to see that comparative best practice care can be delivered in regional cancer centres with the support of the highly skilled surgeons and clinicians and multidisciplinary team members. But it grieves me that the only place to go for cancer therapy is a metro centre.
But here we're really talking about the staging process, so you know what the woman's got.
Yes, and I agree with you. That's the ideal scenario. If we had regional cancer centres with perhaps visiting gynaecological oncologists and the whole other setup, fantastic, and that's the solution.
It'd be the ideal solution because you'd upskill the local gynaecologist who'd be willing to take on and operate with someone like Michael.
And provide appropriate follow-up.
So tell me what you do with women with endometrial cancer, Kath. Prior to treatment, just give me the spiel.
So prior to treatment, I would see them in a pre-admission clinic to be going through with them what they can expect in terms of their surgery, their recovery process, and how things will follow once we get results. So giving them a sort of timeline so they're aware that we will not have results immediately, that they may have gone home before they have those results. And if this is a woman from the country, and frequently it's another trip to the city for them, but making sure as well that we are doing all we can to facilitate that trip to the city, that there is support for their family who are coming down with them, that we've completed things like IPTAS forms so that there's financial support, because the whole cost of transitioning to the city, even if it's for a week, and your partner staying in a motel while you have your surgery, and
quite crippling.
Is considered crippling. So a lot is preparing with information, and then taking things very much as we find their pathology to looking at the next step, because as we see them for the first time, we often don't know what that next step is going to be. but sort of establishing that relationship.
So just talk about the range of treatments that are available. So there's surgery. Is it always radical?
No, it's not. I mean, basically, what our management of these patients include preoperative imaging, so we've got a reasonably good idea before we go in there that they don't have metastatic disease to their liver or to their lungs.
So this is PET?
No, we do usually an MRI or a CT scan of the abdomen and chest. So we want to exclude obvious metastatic disease. We're also very interested in, obviously, enlarged lymph nodes in the para-aortic and the pelvic area. But if they are not enlarged and we go in, it depends then on what sort of cancer. Is this a high-risk cancer? How much of invasion is there into the myometrium? Is there any invasion down to the cervix? Is there any spread to the tubes and ovaries? And that's done with a frozen section. We do the hysterectomy and we send it to a pathologist, and then we sort of look at each other lovingly across the table while it takes 20 minutes for the pathologist to phone us with the result. And then that will dictate whether we go on to, and it's not a lymph node sampling, it's a full pelvic lymphadenectomy, remove all the pelvic nodes and the para-aortic nodes if required. And then depending on those...
if you like, a sentinel node shows up as positive?
No, we don't do sentinel nodes. Under investigations at the moment, whether sentinel node will be of value, no one really knows.
So just who gets the bilateral lymphadenectomy?
Patient who has either a grade 3 tumour, a serous tumour, a clear cell tumour, any tumour that's more than halfway through the myometrium, any tumour involving the cervix, and any tumour that involves the tubes or ovaries. So that's around about 40% of patients overall end up with the much larger operation with the attendant morbidity, particularly in the obese women, and which is not an easy operation, believe me.
And lymphedema is a risk there too.
Yeah.
Yeah, particularly if they are followed up with radiotherapy.
What about adjuvant therapy?
Well, if the woman has positive lymph nodes, then she's usually treated with radiation, or she may go on to a trial. And Australia's got, or as part of a large international trial called PORTEC-3, and that's using chemoirradiation followed by 4 cycles of chemotherapy to see if that reduces the risk of recurrence. So she would either go on that trial or she would just get full pelvic irradiation or irradiation to the para-aortic area if that was involved.
And some people are trying brachytherapy.
So brachytherapy is given in the situation where the
Just to explain for those, that's radioactive seeds essentially.
No, brachytherapy is given in this situation, Norman, through a cylinder. So it's given as a cylinder to the top of the vagina, and that is afterloaded. So no anaesthetic is needed. The patient's in a quarantined room. The cylinder's put into the vagina, and then a machine automatically, and from a distance, loads the top of the. It's just like a large vibrator.
So it's high rate brachy.
High rate brachytherapy, and that's given to patients whose lymph nodes are negative, but who are at higher risk of having recurrence at the top of the vagina.
And does hormone treatment work?
We don't use hormone treatment in an adjuvant setting anymore, but hormone treatment, including Provera, medroxyprogesterone and tamoxifen, are used in advanced disease. Yep.
So post-operatively, Kath and Jenny, when you see these women, I mean, I'll start with Jenny. I mean, so they could have had fairly radical treatment, and this would have enormous psychosexual effects on them.
Absolutely. This is huge surgery. It's huge surgery in physical terms, and it's certainly huge surgery in emotional terms. And as I'm sure Kath will attest, these women take a long time to recover, and as Marjorie told us, they need enormous support to get through what is an extremely challenging time, both in terms of mortality and in terms of sense of self-identity.
What practical advice do you give people here?
It varies very much on the woman, and I think this is where we have to have quite a detailed discussion and conversation with them to find out what their concerns are and what they're worried about. As we've said, lymphedema can be an issue for these women. We know that there are things that women can do to reduce their risk of developing lymphedema, but also if they do develop it, that they have very quick referral to a lymphedema therapist, which will manage the problem. So it's individualising what that woman needs, so giving them practical advice, discussing with them relating to how their sexual function has been before the operation. And for quite a few women who are sexually active, that whole fact of having postmenopausal bleeding is going to be something that's affected sexual function before they were even diagnosed. they may have concerns and misconceptions. So we need to be dealing with those appropriately, but definitely not making any assumptions that are often made, because these are generally postmenopausal women, or people look at them and think, well, she's very large, I'm sure she wouldn't have sex. That we don't neglect this when discussing things with them.
And I should tell you that the National Centre for Gynaecological Cancers is in the process of developing clinical practice guidelines for endometrial cancer with Cancer Council Australia, and there's a working group chaired by Alison Brand. Let's go on to our last case study. Mrs. Mills, she's 86, lives in a residential aged care facility in your country town, Jenny. She has limited mobility and severe cognitive impairment. And the staff report that she's got blood-stained vaginal discharge. And her daughter rings you up, Jenny, to go and have a look at her mother, and comes with you.
And this is a really tricky situation, Norman, and it's one I encountered last week. So the important thing, obviously, is to see this patient's bleeding in the context of their health in general. And certainly my first port of call is to try and make a diagnosis and try and establish what's causing the bleeding. So again, I will examine Mrs. Mills as best as I can, and sometimes that's quite tricky, on a soft bed in the residential aged care facility. As I said, my bent would be here to try and establish a diagnosis in terms of where the bleeding's coming from.
Why?
Because I think it's important in talking to the daughter and about what to do about Mrs. Mills' problem is to give some idea of what the diagnosis is, and then I can give her a prognosis.
Do you agree with that, Peter?
I do, yes it is. Especially if it's a benign condition, they can be reassured. If it's a malignant condition, then they need to have the discussion about treatments which are perhaps not invasive, like surgery, such as progesterone treatment, Mirena treatment, something to stop a bleeding.
So what would you do after you've done the examination, and what sort of diagnostic? It's going to be hard, and it's probably to do the transvaginal ultrasound on her.
Well, it is, and I mean, this is obviously a situation where the pipette, the endometrial biopsy, would be hugely useful. So if that was possible for me to get the patient to the gynaecologist or access someone to do it, well, then that's obviously a great outcome. And if we can get the diagnosis with the pipette, then we're in a position to discuss with the daughter what the low stress options are as well as the high stress options, given this lady's comorbidities.
And if the family says they want everything done, Michael?
Oh, well, I think you've got to respect that, and it's a joint decision, and it's the family, and it's the family doctor involved, it's the local gynaecologist, everyone's involved with, and there are no easy answers to this, Norman, and I think it's people sitting down as a group and trying to work out what's the best for this woman. And there's no algorithm that we could write to say this is what you need to do, because every situation like this is dealt with in an entirely different way from patient to patient. It's respecting the family's wishes and also respecting the woman herself, even though she's demented.
So what you're saying, Peter, is you could put in a progesterone IUD?
Well, if the bleeding is what is making her upset, if she's aware of that bleeding, then it can be reduced for some months just by inserting a Mirena, which is something that can be done under very light anaesthetic in a patient like that.
And some people give a quick blast of external beam.
Yeah, I mean, if this was an endometrial cancer, then a single or two fractions of radiation treatment would be enough to control the bleeding, because that's basically what you're trying to do here, is to make her symptom-free for whatever life she's got left.
And what sort of death is it?
Well, endometrial cancer it can be an awful death, and that's why it's such an important disease for us to be talking about, because it can recur locally and go into the bladder or the rectum, and that causes fistulization, which is the worst possible way for anyone to live their life, or it can metastasize, usually to the lungs would be the common site. But under those circumstances, progestogens are really pretty good. Yep.
Two last questions on our webcast. In young women, we've kind of dealt with this before, but we'll come back to again. Dina Case from Queensland Health asks, in young women with oligomenorrhea and polycystic ovarian syndrome, is there any benefit in screening ultrasounds for endometrial thickness, and if so, how often?
No, but I think the answer is no, not screening, but It's a fabulous question, because we need to sit down with these young women and say that they are at risk of developing endometrial abnormalities, and they can protect themselves. And they can do that with cyclical progesterone, a Mirena, or just a pill. And they need to know that so that they don't end up with an unexpected endometrial cancer in their 30s or early 40s when they're trying to have children.
Did you want to add to that, Peter?
No, I quite agree.
And a comment from Effie Parakilis, who has asked a couple of questions before. We refer to our local gynecology, we must refer, she says, to our local gynecology outpatients department, who then liaise with a visiting gynaecological oncologist from Sydney, which is that partnership
That's
that
fine.
you were talking about earlier. So what are your take-home messages for people watching, Jenny?
Well, I think the really key one is don't ignore bleeding, and bleeding is a potentially troubling symptom. So I think, and we will have shortly some guidelines that we should be able to refer to.
This is the Cancer Australia.
Cancer Australia, which have some really helpful algorithms both for postmenopausal women and also for peri and premenopausal women as well. And I guess that just underlines that bleeding is a symptom we need to take seriously.
Peter?
Well, having travelled around Australia over the last few years, I think the GP really must take responsibility to expedite the referral, not just to give the patient a letter to say make an appointment, because when she rings up, as you know, the shortage of gynaecologists in the country, she may have a 6-month waiting list, and I'm sure that's not going to be to her advantage. So the GP should even make a phone call and make sure that woman's seen within the week.
It's not slip between the cracks.
No.
Kath?
That we shouldn't underestimate the impact of endometrial cancer on these women, often because they're postmenopausal, and that the majority are treated and cured with surgery alone. We sort of see it sometimes as a relatively minor cancer. They still have psychological and physical disease and treatment-related sequelae to cope with for many years after, and we need to be able to address those appropriately.
Beat your breast, Professor Quinn.
I think the take-home message is more women die from this disease than cervix cancer, and that we've got the opportunity to talk to women in family practice, to warn them about the effects of obesity and diabetes, and get them to try and institute some intervention to reduce their risk.
Thank you all very much indeed. I've learnt a lot. Great programme. And I hope you've got a lot from the programme too, this programme on endometrial cancer. This is this programme and the first in our series on gynaecological cancer, and if you saw it, it was on psychosexual care. They can both be ordered free from the Rural Health Education Foundation. Our thanks to the National Centre for Gynaecological Cancers for making the programme possible, and I'm sure that when that guideline's available, it'll come up on their website. But also thanks to you for taking the time to attend and contribute. Now let us know what you thought about the programme by filling in an evaluation form, and if you're watching the webcast, by submitting a comment in the text box on your computer screen. And if you're interested in obtaining more information about the issues raised in the programme, there are a number of resources available on the Rural Health Education Foundation website, rhef.com.au, and the Cancer Australia website at canceraustralia.gov.au. I'm Norman Swan. See you next time.